Eamon, episode 3, going live with Obs and Gynae. A very interesting episode where we'll be going through abortion care as well as labor and delivery with Jaya and Priyanka. They have done a really amazing job with these teaching sessions, so definitely tune in. Also, join our S.Dot's Facebook group, join our S.Dot Slack, and like and subscribe to our Medics.Academy YouTube channel to keep up to date with all of our amazing content. And first up is Jaya, so take it away, Jaya.
Okay, hi guys. My name is Jang Tan, and I'm a fourth-year medical student from the University of Aberdeen. So this is the part one. This is part one of the labor and delivery series. And this lecture is a result of the Medics.Academy virtual elective program, which I highly recommend you guys to sign up. Link in the description box below. Make sure you check out the part 2 and part 3 of this 3-part series on labor physiology. Again, the link is in the description box below. Please like and subscribe to the Medics.Academy YouTube channel, where there'll be videos just like this, and we'll be uploading consistently. If you are a medical student and you're interested in just anything medicine, sign up to the S-Docs free program. And I feel like this labor and delivery series will be especially helpful to those who are hoping to get a refresher on basics of repro medicine, and also those who are going to go on their clinical placements to maternity hospitals, where you get to see a mother going through labor, and this will take you through the steps so you'll understand what's going on as you see it. So let's start things off with sort of a philosophical question. Why is it called labor in the first place? Labor, when you think of it, is associated with hard work, and it is hard work delivering a baby into this world, delivering a life. And as medical students, we learn about science, we learn about the science of creation of life and embryology. And labor is arguably the last bit of that journey, but it's arguably the most important part, where a lot of things can go wrong, and it's a very sort of interesting part of the whole process. So this is what the whole talk is about. I wanted to piece apart and lay out in front of you very clearly each component, each stage in labor and delivery. So this brings me to what I hope to achieve in this webinar. So my aims and objectives is I hope for you guys listening to come away with a good understanding of the physiology of labor. I want to clarify some difficult concepts, some difficult terminology that medical students often get mixed up with. And finally, I wanted to take you from womb to birth, the point of view of a patient, of a mother going through delivery, and I'll do that in the form of a case scenario. And we have this really special case, and I'm going to introduce Sophie Turner. I think a lot of people will know her. You might know her from Game of Thrones, where she played Sansa Stark, and she's come a long way. She's now pregnant, 36 weeks in, so it's quite a long. She's almost there, and she's a primary gravida, first-time mum. She's not had a really clear birth plan, but she knows she wants to go through the vaginal delivery, and just so far, her pregnancy has been normal and smooth sailing, which is great, which is what we want. So before we talk about labor, let's talk about the relevant pelvic anatomy. Let's build a good foundation. And what the first thing you learn about pelvic anatomy is usually the difference between false and true pelvis. And these are the things that medical students get really mixed up with. So starting with the false pelvis on the right, you can see that this area is indicated in the green blob there, and it's sitting above the true pelvis. So the false pelvis is essentially the lower part of the abdominal cavity. And this green bit, if you can imagine, it houses the cecum, the appendix, the sigmoid colon, the distal part of the gastrointestinal tract. And this false pelvis is bounded by the pelvic brim. And if you can imagine the false pelvis to be a basin of sort, the pelvic brim is essentially the rim of that basin. So that's a very crude explanation of false pelvis. Moving on to true pelvis on the right there, you can see that it's indicated by the pink area, and the top of the true pelvis is bounded by the pelvic inlet and the pelvic floor at the bottom. The pelvic floor is a group of muscles that form a hammock that hold in the ovaries, the uterus that are in the true pelvis. And perhaps this is why the true pelvis is called the true pelvis, because it houses the real baby-making organs. So this tool I found really useful. It's an open source kind of thing, and it's a 3D skeletal diagram which you can fiddle and play around with. And I think that that's really useful for understanding and visualizing pelvic anatomy rather than from a 2D sort of picture in a book. So let's talk about pelvic anatomy. So on the rotating sort of GIF on the right there, you can see what the pelvic inlet actually is. And the pelvic inlet, what's important here is you need to know the bony landmarks that make up the pelvic inlet. And first things first is the sacral promontory. This is part of the sacrum where it juts out. It's a bony prominence, you could say. And from there, we go to the arcuate line, to the alar margin, and finally to the pecten pubis, which is essentially the attachment of the pectineus muscle. And then you have the pubic symphysis, which is a ligamentous joint indicated by the white rectangle there at the bottom. And this joins both pubis together, and that's the pelvic inlet. So the pelvic inlet is essentially, you could think of the entry point of the pelvis, the point where the fetus head has to maneuver and enter. So we come on to the pelvic outlet, and the pelvic outlet is starting over the pubic symphysis, but we need to orientate ourselves. So where is this? Pubic symphysis, if you remember, we were looking at the woman in front, and now if you imagine, we're looking at the woman from below her, which is not very appropriate, but for the sake of this explanation. So pubic symphysis, we're going from there to the ischiopubic ramus, and this from there to the sacrotuberous ligament. And why is it called the sacrotuberous? Because it joins from the sacro to the ischial tuberosities. And finally, to the coccyx, which is what we call the tailbone. Just to complete that circle, we have again the sacrotuberous ligament, ischiopubic ramus, and we have the diamond that forms the pelvic outlet. And this is the exit point that the fetus has to maneuver to escape or get out of the womb. Very simple. So that's relevant pelvic anatomy. One more anatomical landmark that I want to point out to you guys is this, the ischial spine. The ischial spine will be relevant later on when we talk about fetal station. Okay, let's check in with Sophie. So Sophie now returns to clinic. She's 41 weeks. It's very close to her due date, and she shows you, she's a bit worried, and she shows you a picture of some mucus discharge that she found this morning, and it has a bit of blood streaks in it. So she asks you, is this anything that I should be worried about? So this is actually a sign of the bloody show. It actually is an indication of the baby showing that he or she wants to come out. You could think of it that way. It's essentially the mucus plug breaking, and that's why it's sort of a mucousy discharge. The mucus plug is it's like a stopper in a wine bottle, and it stops the baby from coming out, and it plugs the cervix. And from there, we can talk about, another classic sign of labor, true labor contractions, as opposed to Braxton Hicks contractions. Now, as we have a false and a true pelvis, we also have false and true labor contractions. And how we differentiate these two is very important because our management will be different. So in a true labor contractions, you can see here that they're going to be regular. They're going to be increasing in duration. They're going to be more frequent as time goes on and more intense. So the pain is going to be unbearable to a point at the end of stage 1 of labor. So in a Braxton Hicks contractions and in a false labor contractions, these are sort of practice contractions for the actual big day. You can think of that. They're going to be coming and going. They're not going to be really intense, and they're not going to get worse and worse or more and more intense. So that's how you differentiate that. So amniotic sac rupturing next is another sign of labor, and that is typically when the mother goes, oh my gosh, my water broke. That is typically seen when a bunch of water just comes out of the vagina. And the amniotic sac is essentially the sort of membrane that holds together all the fluid that surrounds the uterus, that surrounds the fetus. And the rupturing of this is a signaling or a herald of labor. So lightening next is the last sign of labor that I want to talk about. And what is this? So lightening is essentially when we have the baby dropping further into the pelvis of the mother, and the baby engaging with the mother's pubic bone. So the mother will typically sort of feel a dropping sensation, and this is quite characteristic of a sign of labor. Okay, so there we have it. We quickly went through the signs of labor and the relevant pelvic anatomy. And that brings me to the end of this part 1 of the labor and delivery series. Thank you, and keep watching for part 2.
That was awesome, Jaya. I feel like I learned a lot about signs of labor and pelvic anatomy. Thanks so much. Now, let's let Jaya teach us about stages of labor in her next teaching session.
So, hi everyone, my name is Jangtan and I'm a fourth year medical student from the University of Aberdeen. This is the part 2 of Labour and Delivery series, and this lecture is a result of the virtual elective from the Medics.Academy program, which is something that I suggest everyone to sign up for. Make sure you check out part 1 and part 3 of this 3-part series on labour physiology, linked in the description box below. And please like and subscribe to the Medics.Academy YouTube channel, where you'll find videos just like this that will be uploaded consistently. So if you are a medical student, you're looking for amazing medical resources, sign up to the free SDocs program, and yeah, the link in the description box below. Let's start with part 2. So in part 1, we went through the relevant pelvic anatomy. We talked about the signs of labor, and now we're going to talk about, and we introduced the character of the story, Sophie Turner. And now let's go over the stages of labor. So let's actually talk, and this is just to give an overview of what you're expecting from this webinar. So breaking it down into 3 stages. Stage 1 with early and active phases. Stage 2 is essentially when the fetus is being delivered. Stage 3 is all about the placenta. So that's how I remember it. Stage 1 is all about the contractions once again. So let's dive into more detail about stage 1. So when we're talking about stage 1, there's the early phase and the active phase. The active phase is when things are really picking up and progress is picking up as well. So from the start of the stage 1 of labor, the end, you can see that contractions will significantly intensify. So by the end of stage 1, you're looking at really painful contractions, unbearably painful. So an increasing intensity of contractions is all due to the myometrium, and this is the muscle layer of the uterus, and it's going to squeeze from the top from the top of the womb, the fundus, down to the bottom in that pattern. The cervix during labor and delivery is very important to facilitate that head of the fetus coming down and the descent of the fetus down the mother's pelvis. So in the cervix, we're looking for effacement, 1, and we're looking for dilation. And what I mean by effacement is thinning. So thinning of the cervix has to happen, widening of the cervix has to happen, and you can see that it also shortens as you go from start of stage 1 to the end of stage 1. So let's get back to Sophie. Let's check in with her. So Sophie Turner, you tell her, yes, this is a sign of impending labor. We do a vaginal exam on her, and sure enough, it is true that she's going into labor, and she's admitted to the labor ward with her pop star fiance, Joe Jonas. So we get back to the stage 1 of labor, and how we like quantifying things. We like quantifying the progress of labor so that we can say there's a failure to progress or there is very poor progression, and then that sort of changes management for obstetricians. So when we're talking at the start of stage 1, we look at you're looking at 0 to 3 cm dilation, no effacement, and the contractions are going to be irregular. When you're going midway of stage 1, you're looking at 3 to 6 cm dilatation. And ultimately, you want to get to 6 to 10 cm dilatation. And 100% effacement is the main goal. And once your contractions are lasting 60 to 90 seconds, a minute or more, that indicates that you're ready, that you're at the end of stage 1 and you're progressing to stage 2. So the magic number here is 10, and how we sort of visually cue our mothers, because it's quite difficult to visualize in your head when you're in so much pain what 10 cm is. That's typically the size of a grapefruit, we tell them, and when you're at that size, at that dilation of your cervix, you're ready to go to stage 2. So checking in with Sophie, she's now dilated to 9 cm, her contractions are extremely painful, and they're lasting about a minute. So from what I've told you, this is in fact stage 1 and active phase. Sophie is in stage 1 at the end of active phase actually. And yeah, so now let's start with stage 2. We're moving on, and we're talking about a key concept here. So this is the 3 Ps, and you might have heard of this. It's going to crop up time and time again when you're learning about repro: powers, passage, and passenger. So why is it so popular? The reason being is that 2 things it tells us. 1, it tells us what's needed, what's essential for a baby to survive delivery. Secondly, it tells us what can go wrong. It categorizes a normal pathology of labor. So starting with powers, that is essentially the power of the uterine contraction. Is it strong enough to squeeze that's needed to squeeze the fetus out? And passage Is the birth canal safe? Is the birth canal wide enough for the baby to pass through? And lastly, passenger refers to the fetus, where the health of the fetus, is it in distress? Is it healthy? Those are all things crucial to having a successful delivery. And another way that we can, use the 3Ps is to categorize abnormal labor. And these are things like what we call inadequate contractions, which are too weak. And you would typically give some sort of drug that would increase the power of these contractions. Next, you have passage. So is there some sort of ascending infection? And things like herpes simplex virus, simple infections are very harmful to the fetus. And so this is what we must take into account when we're looking at a delivery or labor. So lastly, we look at the passenger. Is the fetus distressed? And we can assess this through cardiotocography, which is assessing the fetal heart rate, and hypoxia, fetal hypoxia, when there's not enough oxygen going to the fetus, and this can result in brain damage. Macrosomia is ultimately when the baby is too big, and that causes problems in it trying to come out. So that's 3Ps in a nutshell. And another key concept of the stage 2 of labor is what I want to dive deeper into. So the position of the fetus is really important in determining how we're going to deliver this fetus safely, this baby safely. So the fetal lie, the fetal attitude, presentation, and station is really important because that will navigate the sort of intervention or management that we follow. So I'm going to dive deeper into each of these terminologies, and it's something that medical students and even I get really muddled up with. So this is going to be interesting. So let's start off with going back to Sophie Turner. She's now in the second stage of her labor. Joe Jonas is by her side, comforting her. And now at this stage, we want to assess the position of her baby. We want to do an obstetric examination. So this is where the fetal lie fetal lie presentation is very important in an obstetric examination because you want to know what you're feeling for. This will come up in OSCEs as well. So we're going to feel for your tummy now. We're going to assess the position of the baby, and the midwife assesses the baby's heartbeat. So these are the results of her examination. And longitudinal lie, fetal attitude, that's normal, cephalic presentation, regular heartbeat. A lot of these things won't mean a lot to anyone. And they can be quite confusing, and they can kind of blend and overlap into each other. So let's distinguish them very clearly and talk about each of them. So let's talk about fetal lie. Number one, it's the position of the fetus in relation to the long axis of the mum. And by that, I mean, draw a line from the top of the mum's head down to her toes, and that's your long axis. And the fetal lie is in relation to that line. So longitudinal will be in line with the long axis of the mum, and this is the ideal lie, fetal lie that we want in all for sort of pregnancies. So transverse lie will be when the fetus is perpendicular to that long axis of the mum, 90 degrees, so it's side on, and this can present some problems of it coming out, as you can imagine. Now, oblique lie is when it's at an angle, the baby is at an angle to the long axis of the mum. Simply, it's not longitudinal, it's not transverse, it's somewhere in the middle. So that's fetal lie, very easy, very simple. Fetal attitude next is essentially the relation of one body part to another. So what I mean by that is normal fetal attitude is basically when the fetus is in full flexion. So if you imagine yourself curling up into a ball, that is essentially normal fetal attitude. When you look at the diagram here, you can see that the back is rounded, the chin is on the chest, the neck, the head is flexed, and the arms and legs itself are tucked in, are flexed as well. So this is normal fetal attitude. This is what we want. And fetal presentation. Now, this is a thing that a lot of people get muddled up with. Don't worry, it's essentially very easy. The first part to descend to the pelvic inlet is the fetal presentation. Whichever part of the fetus that's presented to you first, that is essentially the fetal presentation. Starting off with the first one, cephalic. So this means head. So head down, or vertex presentation is another way of saying cephalic. And this is the ideal presentation of the fetus. Next, we have breech, and there are three types of breech, or three variants, which is complete, frank, and footling. And complete breech is when the knees are bent, and the feet and the bottom will be the presenting part. Frank breech is when the baby's legs are folded flat up against its head, so the only presenting part is the bottom. And lastly, footling breech is when you might even see a foot dangling out in the vaginal introitus, and that is footling breech presentation. So breech presentation is associated with, it's not ideal. So what we would like to do or usually do is an external cephalic version. This is just literally a uterus massage that the midwife or the obstetrician does at 36 weeks gestation. And this is able to turn the physically manipulate fetus into the position that we want. So longitudinal and cephalic. And this can be done for a transverse lie as well. So that's a bit of a clinical management for you guys. So shoulder presentation, now moving on to the next one, that's when the shoulder is literally the first presenting part, and you may even see an arm dangling out the vaginal introitus, and usually these will be straight away to cesarean section. Okay, so that's fetal presentation in a nutshell. Let's look further into cephalic presentations and all the variants that can arise from that. So a very key landmark of this, when you're understanding this, is the occiput. So the back of the baby's head is where you landmark yourself, and that's indicated in the top right corner by that green plate of bone there. So now looking at the label diagram, we can see that the pubis is on the top, the tailbone is at the bottom, and just to orientate ourselves, that is the mother in a lithotomy position, and you're looking front on. So starting with the right occipital anterior. So why is it called this? Let's break it down. The occiput is on the right, patient's right, so it's right occipital, and anterior presentation because the nose is facing the sacrum. So this is ROA, and straight occipital anterior. If you imagine a line going from the pubis down to the tailbone, this is the axis. So it's straight on, it's straight occipital and anterior because the nose is facing, once again, the tailbone. And then you have the left occipital anterior because the occiput is on the patient's left. And the occipital anterior position is associated with a better it's better outcome. And occipital anterior is thought to be the best or ideal cephalic presentation. Why? Because the occipital anterior means that the chin is tucked onto the chest, the head is flexed, and so the smallest part of the head will be applied to the cervix first. Best outcome and the easiest delivery, apparently. So going to the bottom row, we can see that there's right occipital transverse as well. Transverse because, again, it's 90 degrees and perpendicular to that axis that we were talking about. So right because it's on the patient's right. And finally, we have left occipital transverse. Same reason, because it's on the occiput is on the left, patient's left. Excellent. So another set of cephalic presentations. So this should be easy right now. The nose is now pointing not to the tailbone, but the opposite direction at the pubic symphysis, and this indicates that it's a posterior presentation. So this is facing the mother's sort of navel or umbilicus. And the right occipital posterior because the occiput, again, is on the patient's right, straight on because it's in line with the axis, and left because it's on the occiput is on the patient's left. Excellent. So that's all the variants of cephalic presentations. Very easy, very simple to understand. And fetal station. Now we come to this, and it's essentially where the ischial spine come into play, which I was telling you about. And at the level of the ischial spines, when the presenting part is at this level, the head, let's say, that means that the fetus has engaged with the maternal pubic bones. And that essentially happens when there's lightening, when I talked about a sign of impending labor, when the baby's head drops into the pelvis. Station 0 is typically when you will feel that. When it reaches to +5, so that's at the level of ischial tuberosities, the presenting part, that is usually when you see crowning of the head if it's a cephalic presentation. So that's fetal station in a nutshell. And that brings me to the end of part 2 of the Labor and Delivery series. Stay tuned for the next part.
Wait. When did I get a cat? Hi everyone, I'm Pedro Rabbit and I'm the HR Live lead. So, what is HR Live? I don't think even I know. HR Live is a weekly webinar series that holds conversations with interesting people across healthcare and a wider society. Thank you, Google. But seriously, HLA Live is this amazing. It's not gonna work.
Hello and welcome to HLA Live. This is the 6th episode of HLA Live.
Good evening, everyone. I am really excited to be chairing tonight's meeting.
Hello, I'm Alistair. I'm a final year Newcastle medical student and a scholar of the HLA. I'm very interested in surgery and I will be one of your hosts this evening.
Hi, I'm Rosie Spooner and I'm hosting HLA Live this Wednesday.
And I'm an HLA scholar and I'm also going to be your host this evening.
Hi, my name is Jess and I recently graduated as a doctor.
We'll start while everyone else ponders because that way they can give better answers than me.
My heart is full of joy this evening, really. And I have my granddaughter with me and my daughter. I haven't seen them since February.
Oh gosh.
So I will be telling them about this event. My granddaughter.
Quite quick, we have ideas, let's do this, let's do that. So we said let's launch Straight Direct, and within 3 months we thought we would be on the market, so that was a bit crazy. But actually we did a pre-launch within a few months, just to kind of, with a simple quiz capture, just to kind of gather some data.
It's a big question and I'm a bit worried that you've got like 3 minutes before we're going to start this. Cool. We're clear. Well done, everyone. That was really cool. That was really powerful. And there were so many really good points made.
So I think I misunderstood the purpose of this video.
Thanks so much, Jan. That was really informative. Keep watching to learn more about the final stage of the labor, and also remember to join our S.Dots Facebook group, join our S.Dots Slack, and like and subscribe to our Medics.Academy YouTube channel to keep up to date with all our awesome content.
Hi guys, my name is Jang Tan and I'm a 5th year medical student at the University of Aberdeen. This is part 3 of the Labour and Delivery series, which is a lecture that's brought to you by the Medics.Academy under the virtual elective program, which I highly recommend everyone to sign up for. Make sure you check out part 1 and 2 of this Labour and Delivery series on labour physiology, and links in the description box below. Please like and subscribe to the Medics.Academy YouTube channel, where there'll be videos just like this and we will be uploading consistently. So we've gone through stage 1 and stage 2 of labour, and to recap, we followed a case study of Sophie Turner in her journey through pregnancy and labour, and where we left off from her story, Sophie was in her 2nd stage of labour, and they did an obstetric exam and found the following findings, which allude to a fairly normal pregnancy and everything was going well. So now we come to her in the 2nd stage, and right now Sophie's pushing with all her might. The midwife calls out. She says that the baby's head is crowning, and my question to you guys is, at what fetal station is Sophie's baby at if it's crowning? So the answer to that is +5 fetal station. So this was discussed in part 2 of this of the series, and so check that out if you want a bit more explanation on that. So yeah, you can see that the head of the baby in the diagram is just coming out and appears very obviously in vaginal introitus. So this is a cephalic presentation that would most typically be seen in Sophie's case. So, at this point, most of the work that will be done is by the uterine contractions up to this point, but after that, all that's left to do is to merely guide the safe passage of this baby out of the mother's pelvis. So most of the work done is through your knowledge of mechanism of labor and the angles that you have to maneuver around so that the baby has as smooth and possible, as efficient as possible delivery. So this brings me on to the next part, which is the mechanism of labor. Now, a common trap for medical students is to look at these list of sequence of steps and just to memorize them, but it's way easier, I find, to sort of understand what's going on in each of these steps, in which I will take you through one by one. So just to make a point before we start is that labor animation videos, mechanism of labor specifically on YouTube, has a wealth of resource for you to check out, and I find it very useful to sort of visually visually and spatially understand it in a 3D sort of view. So check those out. I found those really useful for my understanding as well. But for the purposes of this lecture, we'll go through them in detail with the use of pictures. So starting off with descent, this is what we've been talking about since the stage 1, stage 2 of labor, as the baby's, as the baby slowly makes its way down further and further into the, the mother's pelvis. So after this point, internal rotation is the next step. And internal rotation essentially means that the baby's head rotates 90 degrees medially so that its face is facing the tailbone of the mother. Now note that the body has not rotated, it's just the head. So at this point, flexion of the head as well as rotation is important. Flexion of the head meaning the chin is on the chest, and you can see that there in the diagram. So at this point, flexion of the head creates the smallest diameter possible of the baby's head and means that it's ideal for coming out of the mother's pelvis. This is the suboccipitopragmatic diameter, and all you have to know about that long word is that it is the smallest possible presenting diameter of the fetal head. So after going through this, the baby then has extension of the head, and this occurs because the head of the baby slips under the pubic symphysis, which is a narrowing when it comes to the birth canal, and so now the head is free to extend, and crowning occurs when the head of the baby actually slips under the pubic symphysis. So finally, we have restitution, and in restitution, don't forget external rotation of the head. So what I mean by that is that the head literally turns towards us, towards the medial thigh of the mother, if that helps you to visualize, and to align itself, to restitute itself, the shoulders and the baby's body realigns itself with that external rotation so that it's all in one axis. So next we have shoulders, and that's the delivery, the anterior shoulder first that occurs, and then finally posterior shoulder. So just to consolidate that concept and that sequence of steps, I like to use analogies, and I love weddings, so combine those two together, and there's a fantastic way to remember the mechanism of labor and the sequence of steps. So starting with engagement, of course, that typically happens in a lot of marriages, but engagement occurs, which is not shown here. The baby's head becomes engaged with the mother's pelvis, and that's a sign of labor. And then you descend down the aisle. Finally, when you get to the aisle, you internally rotate, you look towards your spouse, and you reach up for a kiss, you extend your head, and restitution occurs with external rotation as you turn away from your spouse and you make your way back down the aisle. So I just find that as a very, succinct way of memorizing, and after having understood steps in the mechanism of labor. So after 10 hours in total, Sophie and Joe's baby is born, a healthy young boy, which is amazing. And 10 hours might seem like a really long time, but in actual fact, this is quite normal for a primigravida, first-time mother. So just to recap, we've gone through stage 1, stage 2, and finally, now that the baby's born, things aren't over yet, and we have stage 3 of labor. So the third stage of labor, what in actual fact occurs is that the uterus undergoes a period of rest, which is about 10 minutes, where no contractions occur after having worked so hard. It deserves some rest, and at this point in time, most of the attention is turned towards the newborn, towards the neonate, to dry it, to assess its health and all of that. But during this time, people will be watching the mum for signs of hypotension, just to look out for hemorrhage, and that is to prevent the number one cause, the number one fear and complication of third stage of labor, which is postpartum hemorrhage. Another thing that you want to prevent in the third stage of labor is retain the products of conception, which will be explained later. So what happens after that 10-minute period of rest of the uterus is that contractions will start to resume. And secondly, the placenta will usually separate spontaneously from the uterine wall and make its way out of the uterus through the vagina. So when you actually feel the abdomen and palpate it, you can feel the ascension and descension of the uterus, and this correlates with the migration and descension of the placenta, and once the placenta reaches the vagina, the uterus will contract and form a hard ball, and just to stop the bleeding. So this is why palpation of the abdomen in the third stage of labor is so important clinically to assess how the mother's doing. So in total, when we're talking about postpartum hemorrhage, blood loss should not be above 500 mils. Any more than this, and it's PPH, very simple. So in usual terms, what we'd usually do is wait for 45 minutes for that placenta to come out, for the bleeding to stop, after which time we say this is prolonged third stage of labor, we need to step in and do something to prevent further blood loss and to get that placenta to come out. But usually even before this time, a lot of hospitals do what we call active management of the third stage of labor. And this is shown to, vastly improve rates of postpartum hemorrhage and to prevent that from happening even at all. So the first thing that you would do is give oxytocin as part of active management. You would then give controlled cord contraction, which just means gentle pull on that umbilical cord to facilitate the detachment of the placenta from the uterine wall. Next, you do uterine massage, which helps retract the uterus. And finally, once the placenta is actually exited, we get the midwife and the nurse to sort of inspect for clean edges, look for completeness of the placenta, just to make sure that there are no signs of it, that any of it is left in the uterus. So that's the third stage of labor. Congratulations, you've virtually helped birth a baby boy. Yay! That brings me to the end of this webinar. Just to summarize what we've covered so far in parts 1, we looked at relevant pelvic anatomy, we looked at signs of impending labor, covering stage 1 of labor effectively. Stage 2 of labor we covered in part 2, and we looked at the various terminology that we would use to describe fetal position. And lastly, in this part of the labor and delivery series, we looked at the mechanism of labor and we looked at how to manage third stage. So that brings me to the end. Thank you for listening to all 3 parts. And remember, this is all part of the learning package that I've created in conjunction with Medics.Academy, which can be found on my Twitter. So give me a like, give me a follow, and also like and subscribe to the Medics.Academy YouTube channel, and like their Facebook page for any updates. Thank you very much. Bye.
That was really informative. Thank you so much, Jaya, for all your hard work. Now Priyanka will be going through medical and surgical abortions in her next set of sessions. So get ready, guys.
Hi everyone, thank you so much for tuning into this webinar. I'm Priyanka Iyer and I recently graduated from King's College London. I'll be starting my F1 job in Obs and Gynae next month in Northeast London. Abortion care is a topic that I'm quite passionate about, and I hope that you find this webinar both informative and engaging. So here's a quick overview of the 2-part webinar series that I created during my virtual medical elective with Medics.Academy. This is the first part, where in the next 15 minutes, I hope to cover all you need to know about abortion care as a medical student. The second part in the webinar series looks at the UK law and a global health perspective on abortion care. So why did I choose this topic, and why is it important for medical students to learn about abortions? I have a personal interest in obstetrics and gynecology and women's health, and abortion care is a core aspect of women's reproductive rights. There's often a lot of stigma associated with the topic, which makes it even more important for us to educate ourselves on this. This topic is often only briefly covered during medical school, in women's health rotations, or during ethics sessions in preclinical years. As future healthcare professionals, it's so important for us to deliver compassionate and non-judgmental abortion care. And lastly, in cases of conscientious objection, which is where medical staff have the right to refuse participation in abortion for personal beliefs, we have a duty of care to our patients to be able to refer them on to other healthcare providers without causing undue delays. Here are some learning objectives that I hope to cover through this webinar. So we'll first look at some of the common myths associated with abortions. Second, look at medical and surgical abortions. And lastly, cover some of the practical aspects of accessing abortions in the NHS. I'm now going to present you with 5 statements, and I want you to take a couple of seconds to think about whether each is a myth or a fact. For the first, a third of women in the UK will have an abortion. Second, if an under 16-year-old has an abortion, the family or caregivers will be told. The third, around 80% of abortions are carried out under 10 weeks. Next, abortion is safer than giving birth for the woman. And lastly, having an abortion can result in depression and infertility. So the first statement is a fact, and this highlights just how common abortions are. 1 in 3 women in the UK will have had an abortion by the time they're 45. The next statement is a myth, as if the young person is assessed as being competent according to Fraser guidelines, then confidentiality will be maintained and their family and carers will not be told. The third statement is in fact true, with 90% of abortions carried out under 13 weeks. Statement 4, this is again a fact because when abortions are carried out in safe facilities and care is provided with trained professionals, it's one of the safest procedures that a woman can undergo. And lastly, as you might have guessed, neither of these claims are true. And it's really important that we reassure women about these when they're looking to end an unwanted pregnancy. So an abortion can be defined as the termination of an unwanted pregnancy. Before an abortion, you usually need to have an assessment appointment. And this happens either at the hospital or the clinic, but you may be offered either a phone or a video assessment. And during this assessment, you may discuss your reasons for considering an abortion. Women are offered the chance to talk things over with a trained counselor if that's something that's helpful. They get to talk to a nurse or a doctor about the different methods available, including any risks or complications. And if it's appropriate, they may also be offered an ultrasound scan to check how many weeks pregnant they are. And they might also be offered testing for STIs. And depending on any medical conditions or the stage of the pregnancy, they may be offered other tests, such as a blood test as well. And when women are sure that they do want to have an abortion, they're asked to sign a consent form. And it's important to reassure women that they can change their mind at any point up to the start of the abortion. So there are 2 main methods by which this can be carried out. And we'll now cover the first, which is a medical abortion. So as you can see from this infographic, a medical abortion involves 2 pills, mifepristone and misoprostol. I was taught of a really handy way of remembering the order that you take the pills. So Miffy has an F for first and Miso has an S for second. So how do these pills work? The mifepristone is an anti-progesterone, which essentially ends the pregnancy. As you probably remember from your reproductive physiology, progesterone is pro-gestation. So it's absolutely vital, both in early pregnancy, where it helps thicken the line of the uterus, and later on in maintaining a healthy pregnancy. Once the pregnancy is terminated by the mifepristone, the next step is to contract the uterus to remove the pregnancy tissue. And this is done by the second drug, misoprostol. And as the name suggests, it's a prostaglandin, which stimulates the uterine contractions. So the second pill is usually taken 24 to 48 hours after the first. And there are a variety of ways, including vaginal, buccal, which is where you place the tablet between the gums and your cheek, and also sublingually, where it's placed underneath your tongue. So with an early medical abortion, which is when abortions are carried out under 10 weeks, the abortion starts 2 to 3 hours after taking the misoprostol. Women experience vaginal bleeding, which is heavy with clots, and this bleeding can last up to 2 weeks, but the bleeding that follows is usually much lighter. They also experience lower abdominal cramping pain, which can be worse than period pain for most women. However, simple analgesia can be very effective for this pain. And lastly, most women complete their abortion within 4 hours, with almost all completing it in 24 hours. There have been some recent changes to guidelines, which have meant that women under 10 weeks of gestation can take the second tablet in their own homes, which allows them to choose a time that's most convenient and comfortable for them. With medical abortions over 10 weeks, there are some important differences and key points to remember. So repeated doses of the second tablet, misoprostol, is given at 3-hour intervals, and women are asked to come in for an inpatient stay. And 50% of women pass the pregnancy within 8 hours. If the pregnancy is over 20 weeks, so between 20 to 22 weeks, doctors usually recommend an injection of digoxin or potassium chloride to avoid the possibility of a live birth, which can be quite distressing for the woman. So the second method that women are offered to terminate their pregnancy is surgical abortions. And the procedure that they're offered depends on their gestational age. So if they're under 14 weeks, they're offered a vacuum aspiration. And if they're over 14 weeks, they're offered the dilatation and evacuation procedure. These procedures can be done under local anesthetic, under conscious sedation, or deep sedation, which is where women have to have a general anesthetic. So a vacuum aspiration is done either with a manual suction, which is this device that you can see now, or an electric suction device. And for these procedures, misoprostol is sometimes inserted into the vagina to help soften the cervix. And this makes the whole procedure much more comfortable for the woman. So after the cervix is dilated, the pregnancy tissue is then aspirated using the suction device. And the entire procedure takes 5 to 10 minutes, and women can go home a few hours later. If women are having a general anesthetic, they need to fast, and it's done as a day case procedure. Many women can go to work the following day if they prefer. Abdominal pain is minimal, and vaginal bleeding can last up to a week. So the second surgical procedure is dilatation and evacuation, which is done for 14 weeks and above. And as the name suggests, it includes dilatation of the cervix. So this is done either using the misoprostol, or you can use osmotic dilators. And essentially what this does is that it absorbs moisture from the tissue surrounding the cervix, and it swells, which then opens up the cervix slowly with little discomfort. The fetus and the placenta are then removed using forceps and vacuum aspiration. The procedure takes around 10 to 20 minutes, and it's usually carried out under sedation or general anesthetic. So both medical and surgical abortions can be carried out safely up to 24 weeks. What's the best method? And essentially, a lot of weighting is given to the individual's choice. For example, many women might not want to have an operation, or if they live with their parents, then an early medical abortion might be quite difficult. Their gestational age is also taken into account. And NICE has some really good clinical decision aids for women to help them decide between the two methods based on what factors are important to them. And I have a link to this at the very end of my webinar. So as we covered at the very beginning, if carried out in safe conditions by trained providers, abortions can be one of the safest procedures that a pregnant person can undergo. This table compares the risks of an early medical abortion versus vacuum aspiration. It's important to note, however, that risks increase in frequency and severity as the gestational age increases. When we look at complications of any procedure or medication, we can split this up into common or less common or rare. So common complications of terminations include bleeding and pain. To a lesser extent, infections can also occur. And it's really important to counsel women because if these infections are untreated, they can lead to pelvic inflammatory disease. And this can present as pelvic pain and infertility later on. Failure of the abortion is another complication. Extremely rare complications, which are specific to surgical abortions, are cervical trauma or cervical tears, which are under 1 in 100, and uterine perforation, which is again extremely rare, 1 to 4 in 1,000 procedures. So post-abortion care is equally just as important, and this should involve safety netting about when a woman should seek emergency help. So women are asked to get advice if they have pain or bleeding that does not get better in a few days, if they still feel pregnant after a week after the procedure, and if they have a temperature, flu-like feelings, or unusual vaginal discharge, because any of these could be signs of an infection. So the clinic essentially gives them a number of a 24-hour helpline to call if they're worried. And if they cannot find the number, they are free to contact their GP or 111. Another aspect of post-abortion care is a discussion about future contraceptive methods. And this is important as fertility returns quite quickly after terminating the pregnancy. So, practical aspects of accessing abortions in the NHS. Abortions, according to the law, can only be carried out under the care of an NHS hospital or a licensed clinic, and they're usually available free of charge on the NHS. There are 3 main ways to get an abortion. First, you can self-refer by contacting an abortion provider directly, and these are 3 of the main abortion providers in the UK. So you have the British Pregnancy Advisory Service, or BPAS, you have Marie Stopes UK, and the National Unplanned Pregnancy Advisory Service, NUPAS. Second, they can speak to their GP and ask for a referral to an abortion service. And if the GP has any objections to abortion because of their personal beliefs, they should be able to refer you on to another doctor without any delays. And the third is contacting a sexual health clinic, sometimes called a family planning or a GUM clinic. and they can then refer them on to an abortion service. So waiting times can vary, but women should not have to wait for more than 2 weeks from when they first contact an abortion provider. So just a few quick key points. So a third of women in the UK will have an abortion in their lifetime. 80% of abortions are carried out under 10 weeks. Mifepristone terminates the pregnancy, and misoprostol causes the uterus to contract. And both of these tablets taken together can successfully terminate the pregnancy. A surgical abortion under 14 weeks can be done with vacuum aspiration, and that over 14 weeks, a dilatation and evacuation procedure is used. And lastly, abortions are freely available under the NHS and can be accessed through the GP, sexual health clinics, and independent abortion providers. And just some useful resources. So this is one of the patient decision aids that are on the NICE website. And essentially you can see all the different factors that women can take into account, and they can basically weigh up which factors are very important to which factors are not that important to them. So it basically empowers women to have these discussions with their healthcare providers and thereby choose the option that works the best for them. And there's a lot of information on the NHS.uk website. Doctors for Choice is a really great organization for anyone that's really passionate about abortion care, and they do a lot of campaigning about decriminalizing abortions in the UK. There are also some really useful videos from International Planned Parenthood Foundation looking at how does medical abortion work and how does a surgical abortion work as well. And here are some references. And yeah, that's the end of the webinar. Thank you so much for tuning in, and I really hope that you found this useful. So please do have a look at some of the other amazing lectures delivered by my colleagues on a variety of topics. This lecture would not have been possible without all the support and guidance from the incredible Medics.Academy team. You can find out more about the Medics.Academy virtual elective in the link in the description box below. I would highly recommend signing up and taking part, as I had a really great experience on the program. Make sure you do check out part 2 of this video next, and you can also find a description to that in the box below. And again, please do like and subscribe to the Medics.Academy YouTube channel, as the content on the channel is constantly being updated. If you are a medical student, I definitely recommend signing up to the free SDocs program. If you have any questions, here's my Twitter handle and email, so feel free to get in touch. I've also left a QR code and link to allow you to provide feedback on this webinar. It shouldn't take too long, and I'd love to hear how you found this session. Thank you.
Thank you so much, Priyanka. And now learn about global health and the law relating to abortions in Priyanka's next teaching session. And remember to keep up to date with awesome content like this by joining the SDocs Facebook group, join the SDocs Slack, as well as liking and subscribing to the Medics.Academy YouTube channel.
Hi everyone, thank you so much for tuning in to part 2 of this 2-part webinar series on abortion care. I'm Priyanka Iyer, and I recently graduated from King's College London. I'll be starting my foundation jobs next month in Northeast London with my first placement in obstetrics and gynecology. Abortion care is a topic that I'm really passionate about, and I hope you find this webinar engaging and informative. So here's a quick overview of the webinar series that I created during my virtual medical elective with Medics.Academy. This is the second part, where in the next 15 minutes, I hope to first take you through the law surrounding abortions in the UK, and then cover the topic from a global health perspective. If you'd like to learn more about the clinical aspects of abortion care, do watch the first part of the series, which goes through everything that you need to know about abortion care as a medical student. So here are some learning objectives for this webinar. So first, we'll go through the abortion law in the UK. Next, go through unsafe abortions and how we define them. Look at some of the barriers to safe abortions around the world, how we tackle these barriers, and lastly, abortion in the time of COVID-19. So, abortions in the UK. 1861, the Offences Against the Persons Act made it illegal for women to get their own abortion and for medical professionals to provide these abortions. In England, Scotland, and Wales, abortions continue to be regulated under criminal law to this day. In 1967, the UK Parliament passed the Abortion Act, which essentially gave doctors a medical exemption for performing abortions, and women were finally able to access abortions that were both safe and legal. The act, however, was not extended to Northern Ireland. 2 doctors are needed by law to agree that continuing with the pregnancy would pose a risk to the physical and mental health of the pregnant woman or any existing children of the family, and that this risk would be greater than if the pregnancy was terminated. 24 weeks. So essentially, the Act was amended in 1990 when a general time limit of 24 weeks was established. Beyond this, women can still receive abortions for limited circumstances, including if there's a risk of death or serious permanent damage to the woman or a serious fetal abnormality. On the 31st of March 2020, one of the world's most restrictive abortion laws were overturned. Abortion in Northern Ireland is now seen as healthcare rather than as part of the criminal law. So women's reproductive rights have been emphasized in the United Nations Sustainable Development Goal 3.7, which states that by 2030, we must ensure universal access to sexual and reproductive healthcare services, including family planning, information and education, and the integration of reproductive health into national strategies and programs. As you can see from this infographic produced by the World Health Organization, a staggering 25 million unsafe abortions take place worldwide. This is nearly half of all of the abortions, with most of these taking place in the developing world. So how do we define unsafe abortions? There are 2 aspects that need to be present and work hand in hand for an abortion to be safe: the person and the location. So an unsafe abortion happens when a pregnancy is terminated either by people that lack the necessary skills or in an environment that does not conform to minimum medical standards, or both. And you can divide unsafe abortions into less safe and least safe. They're less safe when they're done using outdated methods like sharp curettage, even if the provider is trained, or if women are using tablets and they don't have access to proper information or to a trained person if they do need help later on. Abortions are dangerous or least safe when they involve ingestion of toxic substances, or they're carried out by untrained persons who use dangerous methods such as insertion of foreign bodies or the use of traditional concoctions. So what are some of the risks of unsafe abortions? So following unsafe abortions, women experience a range of harms that affect their quality of life and well-being, with some women even experiencing life-threatening complications. The major life-threatening complications resulting from the least safe abortions are hemorrhage, infection, and injury to the genital tract and internal organs. So incomplete abortion, hemorrhage, infection, uterine perforation, and damage to the internal organs are some of the risks of unsafe abortions. What are some of the barriers to unsafe abortions? So, restrictive laws. A Lancet study in 2017 highlighted an important association between countries that have restrictive laws and higher rates of unsafe abortion. Essentially, criminalizing abortion does not decrease the rate of abortion. It just increases the number of procedures carried out by inappropriately trained staff using methods that are not recommended. Furthermore, restrictions have a disproportionate effect on vulnerable groups. And this includes adolescents, rural, poor, and the incarcerated who already face highest rates of unintended pregnancy and abortion. You also have funding-related restriction. So economic barriers have massive implications on access, which includes decreased funding for abortion providers and fewer educational opportunities to train medical and healthcare staff in the provision of safe and accessible abortion services. Social and cultural barriers. Terminating a pregnancy in certain cultures is regarded as unacceptable, which feeds into the stigma faced by both healthcare providers and women seeking this basic essential service. This also affects healthcare policy, as abortion becomes increasingly marginalized from mainstream healthcare. Religious institutions also have a role to play, both at an individual level, causing avoidable delays in access, and systemically, through campaigns to restrict local and national policies. A population that's often overlooked are intersex people, transgender men and boys, and people with other gender identities that have the reproductive capacity to become pregnant. This group already face a lack of access, and they often have an added barrier of stigma and biased views from their healthcare provider, including presumptions that they do not need access to contraception. Fear of judgment and previous negative experiences can often be a significant restraint to women who approach a healthcare professional and want to discuss terminating their pregnancy. Financial costs for the woman. This can be a really important barrier. And there are a lot of indirect costs. For example, for women in rural areas, costs of travel and time off work can be significant. Availability of services and a lack of healthcare providers often go hand in hand. With regards to the health system, marginalized abortion care results in fewer trained staff providing this much needed service, which makes it difficult for patients to book appointments. This might delay patients from getting timely care in earlier stages of pregnancy, when medical abortion is much more feasible with fewer accompanying complications. Moreover, lack of training opportunities and restrictions, which include only allowing doctors to provide abortion care, can further limit access to this essential healthcare service. So how do we start to tackle these barriers? Comprehensive sexuality education, access to affordable contraception, and safe abortion care are absolutely fundamental for us to ensure that women around the world have access to care that's safe, compassionate, and non-judgmental. So I'll focus on technology and education as drivers for change in order to start tackling some of these barriers. Technology. So telemedicine is a really powerful resource, particularly in rural, hard-to-access areas, allowing abortion care to be provided earlier and closer to the woman's home. Telemedicine makes it safer to get abortion drugs in the mail, as seen on Women on Web, Women Help Women, and Safe to Choose, which provide an online consultation and a review by a clinician who then remotely authorizes this medication. It is important to stress, however, that there is often a loss to follow up with these cases, and it's crucial that these women know when to access secondary care in instances of a medical abortion. The reduced need to travel, decreased costs, and increased availability of services has benefits to both staff and women requesting a termination of their pregnancy using telemedicine services. Technology can also be used to deliver comprehensive education surrounding sexual and reproductive health, and this can meet the direct need for more training for healthcare providers through e-modules and apps. E-learning improves access, can reach a wider target audience, and has a reduced overall cost of delivery. Education. So reducing stigma. The media has an incredibly powerful influence on stigma and shapes our perceptions. An increased risk of breast cancer and depression post-abortion is often falsely portrayed by the media, and this falsely portrayed belief is then strengthened by crisis pregnancy centers. It's really important to showcase women's stories through exhibitions and documentaries to truthfully portray the reality of abortion services and highlight just how common it is for women to terminate their pregnancies, thereby normalizing and reducing some of the stigma associated with the experience. Education can also be used to train medical students and healthcare providers. So often the stigma and preconceptions that abortion doctors have and face starts at medical school. Efforts to destigmatize and integrate abortion training into medical education can ensure that the doctors of the future can confidently navigate these conversations surrounding terminations and even pursue postgraduate training in abortion care if they are interested. Moreover, involving a wider range of healthcare workers in the provision of abortion care would go a long way in starting to tackle the shortage in abortion providers. For example, allowing advanced practice clinicians to provide first trimester abortions, and pharmacies in expanding access to medical abortions. Again, the provision of accurate information and safety netting is fundamental in these settings, and stringent training that covers all aspects of abortion care should be provided. Comprehensive sexual education. So young people have the right to access information about their reproductive health. A report undertaken by Brooke highlighted examples of widespread bad practice where some schools failed to address abortion at all, and some invited anti-abortion groups to talk about contraception and abortion, thereby providing misinformation and again reinforcing the stigma and distress around the subject. A really great project run by Doctors for Choice UK, which was piloted at UCL and which I helped set up at King's, involves training medical students to provide evidence-based pregnancy decision-making workshops to schools to empower young people with this information. So, abortions in the time of COVID-19. Unless action is taken now, Marie Stopes estimates that up to 9.5 million vulnerable women and girls lose risking access to their contraception and safe abortion services in 2020 due to the COVID-19 pandemic. What are some of the practical solutions to this to help remove the waiting times and delays? So first, having abortion drugs on the essential medicines list would help avoid any disruptions in their supply. Second, increasing the range of people providing services, which is something that I've touched on earlier. Third, using telemedicine. So an example of this is BPAS, the British Pregnancy Advisory Service, who have been providing pills by post for women up to 10 weeks. Digital media campaigns are really important to educate and inform women about the changes to abortion services and to reassure them that these services have not ceased during the pandemic. So the information on this slide is from the latest guidance on COVID-19 and abortion care issued by the Royal College of Obstetrics and Gynecology in June 2020. So as you can see, when a woman requests an abortion, they're offered remote consultation, either via video or telephone. And they're also provided with written information prior to this consultation, so either via email or they're sent a link. And for remote consultations, the same standards apply as a face-to-face consultation, so women are given enough information and time to allow for the opportunity to ask questions and to give informed consent as well. And they're either asked to collect or they're posted their abortion medications, any additional medications, and 14 days after the medical abortion, they're offered a remote or a self-assessment of their outcome using a low-sensitivity pregnancy test. And after these 14 days, they're also offered the discussion of contraception options. And if appropriate, this contraception can also be included in their abortion pack. So just some of the key points covered during this webinar. Abortion is available legally throughout Great Britain as detailed under the 1967 Abortion Act. Unsafe abortions can be defined as those which are carried out by people that lack the necessary skills in an environment that lacks minimal medical standards. Risks of unsafe abortions include incomplete procedures, hemorrhage, infection, uterine perforation, and damage to internal organs. And some of the barriers to unsafe abortions include restrictive laws, financial restraints, social stigma, and a lack of healthcare providers. Technology and education can be very useful drivers to tackle some of these barriers. And abortion is essential healthcare, and this can often be disrupted during pandemics. So here are some useful resources. So Doctors for Choice is a really great organization that does a lot of campaigning with regards to decriminalizing abortions. The second is the World Health Organization. So they have a lot of information on unsafe abortions and also statistics regarding abortions worldwide. There's a really great course on how to use abortionpill.org, and the medical student course basically provides critical knowledge and allows medical students to be prepared to support women who seek abortions or those who have already had a medical abortion. And Safe Access is another really great website with evidence-based best practice guidance for implementers and policymakers on safe abortions and post-abortion care programming. So thank you again for tuning in, and I really hope that you found this webinar useful. Please do have a look at the other amazing lectures delivered by my colleagues on a variety of topics. This webinar would not have been possible without all of the support and guidance from the incredible Medics.Academy team. You can find out more about their virtual elective in the link in the description box below. I'd highly recommend signing up and taking part, as I had a really great experience. Make sure you do check out part 1 of this video next, which, if you haven't seen this already, which you can also find in the description box below. Please do like and subscribe to the Medics.Academy YouTube channel to be notified about future videos, as the content on the channel is constantly being updated. If you are a medical student, I definitely recommend signing up to the free SDocs program. If you have any questions, here's my Twitter handle and email, so feel free to get in touch. I've also left a QR code and a link to provide feedback on this webinar. It shouldn't take too long, and I'd love to hear how you found this session. Thank you.
That was great. I feel like I learned so much. What do you guys think? Thank you so much to Jaya, and thank you so much to Priyanka. Our next episode will be Bring On the Food and the Happiness. Remember to get notified ASAP by joining the SDocs Facebook group, joining the SDocs Slack, as well as liking and subscribing to the Medics.Academy YouTube channel. Bye guys, thanks for tuning in.
Hi, so my name's Zaid. I am an F1 in West London, and I just completed the Medics.Academy training in teaching day 3 course.
I think it's structured in a really nice way with a lot of resources you can permanently access. The course isn't over after 3 days. You've got a ton of online content that you can always revisit, and I think that is fantastic.
I thought it was a great way to learn through having a full day at the start and then 2 later days of self-study. It really allowed for flexibility and allowed us to fully engage in the course.
It also made me feel better prepared to deliver teaching remotely or digitally.
It's really interactive. There's a lot of small group feedback session, exchanging ideas and learning people's perspective.
After actually doing this course, I realised that teaching is more of a science, and it's really important to get clear feedback so that you can improve your teaching.
This course also encouraged me to think thoroughly about what my audience actually wants from my teaching session, and also how I can keep them better engaged.
Really great and fantastic to get such fantastic lectures from experts in the field throughout the 3 days. It was also interesting to learn from others taking part on the course because we all have different levels of experience, so it was interesting to gain their perspective on things too.
I learned not just about different style of teaching, I also learned about what is medical education, how to build a career in medical education.
Overall, I learned a lot from the teaching course.
I think it's a really well done course.
I really enjoyed it.
And I really found it very enjoyable.
That's what I thought of the whole course, and I really enjoyed it, and I would recommend it to other people.
So thank you for letting me participate.